Hello everyone, welcome to our YouTube channel once again. Today we'll be covering the development of the urinary system. This is a lecture after we did the histological organization of the urinary system. So what are we going to cover in our session of the development of the urinary system today? So today we'll be going to talk about the development of the kidney and the kidney systems, then talk about the development of the bladder, then talk about the development of the ureters, the development of the adrenal glands, and then look at some of the congenital anomalies that we know of the urinary system. So ideally, you're supposed to start by knowing the germ layers, the various germs layer. So for example, here we can appreciate we have the ectoderm, then you have the endoderm here. At this point, this is a surface ectoderm because you already have the neurotip, the neuroectoderm. And then this is a paraxial mesoderm. Then you have the intermediate mesoderm. Then you have the splanchnic. And then we have now the somatic part of splanchnic, the part of mesoderm, of the lateral plate mesoderm. So we have paraxial, intermediate. Then you have the splanchnic part of lateral plate mesoderm. And then the somatic part of lateral plate mesoderm. So ideally, our kidneys, the urinary system and the reproductive system will come from the intermediate mesoderm, as you can see here. So this intermediate mesoderm of ours will give us the nephratomes, the various structures that form the urinary system. The image on our right shows us, on our left shows us now the gross structures. So you can see the kidney, you can see the ureter, and you can see the bladder. So in the kidney, we can appreciate we have some constrictions. So you can appreciate you have the constrictions around the pelvic brim. You also have another constriction here at the ureterovesical junction, and then the pelvo-ureteric junction here. So you have those three constrictions. Then you have the bladder here, and then on the distal aspect, we have the urethra. So this just to remind ourselves of the histological organization of the urinary system. So the first thing that we start us off is by looking at this. So what you're looking at right now is actually the bladder. So it has a mucosa, it has a muscular component, which is now the retractor muscle, and then it has a serosal bit. Then the image on our right is showing us a higher magnification of the bladder. So this is the bladder, the transitional epithelium, the lumen of the bladder, then the muscular component with the three parts. Then you have the adventitia and the serosa. Then on this image, it's just showing us the transitional epithelium. This image is showing us a higher magnification of the cortical part of the kidney. You can be able to appreciate the renal corpuscles and then the tubules there. Then the image here, you can be able to appreciate this is a ureter. You can see the star-shaped lumen, and then it has a mucosa. Then it has a muscular bit, and then you can be able to appreciate it has a very small serosa. Similar thing you can be able to appreciate. We have a mucosa, then you have the muscular component there. Then the image now on the top right is showing us the adrenal gland. So the adrenal gland has a cortex and a medulla. So this is a medulla with the central adrenomedullary vein. Then you have the cortex with the three layers. So zona glomerulosa, zona fasciculata, and zona reticularis. So those are the three layers. So a point to notice that you need to know the functions of those three layers in terms of what they usually produce. Yes, and you can see them here. Then you have a fibrous capsule now that is covering it. Okay, so let's go to the kidney. So remember we said the kidney it will develop through three kidney systems. So the tissues of origin is that we say it's intermediate mesoderm, where is the site on the posterior abdominal wall. And then it has three stages. The three stages are pronephros, mesonephros, and metanephros. And they develop with time. So pronephros are the earliest, mesonephros they are after pronephros, and then metanephros are the last ones that give us the permanent kidneys. Then we start with the pronephric stage. So the pronephric stage, you can see it here. This is a pronephric stage, the nephrotons now. So they are the first primitive kidney which develops in the cervical part. So they develop in the neck of around the neck region. So they usually regress within the fourth week. Why? Because they usually don't have glomerulus. Yes. And another reason why they usually regress is that they are not the permanent kidneys. Yes. And usually 7 to 10 of them of those. So what you usually don't have the excretory beats, but usually have the collecting beat. So you have pronephric tubes, and yet you don't have the glomerulus, the Bowman's capsule. Yes. And then the fate of those pronephra is that they usually degenerate, except the pronephric duct, which persists to become the mesonephric duct. So here you can appreciate these are the pronephros. They have a pronephric duct. This pronephric duct will will persist to become the mesonephric duct. The other kidney system that we'll talk about, as you can see on the image on our right, is the mesonephros. So the mesonephric stage is the second kidney system that will appear. So you can tell the degenerating pronephros are there, then you have the mesonephros. The mesonephros will come immediately after pronephros. So remember, pronephros were regressing at around the end of the fourth week. So in the beginning of the fifth, or in the end of the fourth week, we'll have the mesonephros coming in, and they will develop around the thoracic and lumbar segments on the intermediate mesoderm. So they come in the fourth to the eighth week, or the beginning of the fifth to the eighth week. And then these ones will be functional. They will be functional because, as you can see here, they'll have glomerulus. So each segment develops 2 to 3 S-shaped excretory tubules. Those are now the glomerulus and the Bowman's capsule. And then also they will have now the tubules going downwards to connect to this mesonephric duct. So the medial end is evaginated by a glomerulus, and the lateral end opening to the longitudinal mesonephric duct, as we talked about. The mesonephric duct will be joined by these mesonephric tubules. But the fate is that this also mesonephros will also regress. The mesonephros will also regress. But the mesonephric duct, this duct, will remain patent, will remain in males, but it will disappear in females. So the mesonephric duct will disappear in females. We'll see the reason why. Yeah, so given that these mesonephric ducts will remain in males, so we can appreciate here the developing gonads. We have is a Wolffian duct, and then we have the Mullerian duct. So what happens is that this Wolffian duct, the Wolffian duct will become the vast difference at this point. Yes, they'll become the vast difference. In females, you can appreciate they degenerate. They degenerate. So these Wolffian ducts are actually our mesonephric ducts. So in males, the mesonephric duct will become the Wolffian ducts, and hence they help in formation of the internal genitalia. So talk about some part of the appendix that is now of the GI, and then also remember even the epididymis as an appendix. So a small portion of the appendix of the GIS, and even the appendix and duct of the epididymis. Then you'll also have the ductus deferens, as we saw here. Then there is some part of the ureter, the pelvis, the calyxes, collecting tubules, ejaculatory duct, and the seminal glands will come from the Wolffian duct. In females, it degenerates, and then it remains rudimentary as epophoron and paraphoron of the mesoovarian. So mesoovarian is a ligament of the ovary. The last kidney system that you need to talk about is now the metanephros. And for the metanephros, the permanent kidneys, you can be able to appreciate them here. So they will develop in the lumbosacral intermediate mesoderm. So that means they'll develop in the pelvic region. So it has nephrons, it has an excretory unit, and also it has a urinary collecting system. So the excretory unit will come from the metanephric blastema. So you can see this mesenchymal connective tissue will give us the excretory unit. So that is the metanephric blastema. And then the ureteric bud will give us now the collecting system. So the ureteric bud is epithelial in nature, and the metanephric blastema is mesenchymal in nature. So we'll appreciate here we'll have mesenchymal epithelial interactions. So the epithelial bud, the ureteric bud will stimulate the metanephric blastema to develop and give us excretory units, while the metanephric blastema will stimulate the ureteric bud or induce the ureteric bud to form the ureteric collecting tubules. So talk about now the collecting ducts, collecting tubules, and even the renal calyxes will be coming from the ureteric bud. So the collecting tubules and the ureter, the urine collecting structures will develop from the ureteric bud. That is now the mesonephric duct diverticulum here that you can see, also known as the mesonephric duct diverticulum. So we already have now the metanephros. So some things will happen. Remember we talked about it developing in the pelvic region. So it has to change in positions in terms of ascending and even rotating. So the kidneys, similar case to the stomach, it will rotate 90 degrees at the convex, as the convex part goes dorsally and laterally, while the hilum becomes medially. So here we'll have now the convex bit going dorsally and laterally, while the hilum, now the concave bit becoming more medially. And then the other one is that we'll have change of shape from lobulation to smooth. And if these lobulations don't disappear, we'll have an anomaly. So we'll have kidney lobulations. And then we have the ascent of the kidneys from the pelvic to the ideally to being retroperitoneum in the abdomen. So they'll ascend from the pelvic region and they go up to the abdominal region where they actually retroperitoneum. And then also you have changes in blood supply. Usually start with median sacral in the pelvic region. Then we ascend to internal iliacs, common iliacs. Then you go to abdominal aorta. So ideally, that is where we'll have where we have the renal arteries coming from embryologically. And we'll have now the final renal arteries coming from the abdominal aorta. But ideally, for the ureters, they will maintain the blood supply. That's the reason why you'll find the ureter will be supplied by various arteries, starting from the renal arteries themselves, abdominal aorta, common iliac. You go to gonadal arteries, that is now the testicular arteries. You go to the median sacral arteries, internal iliac, because they'll have a segmental pattern of blood supply. So that's some of the changes in blood supply of the kidney. But the ureter will maintain the blood supply in the various segments as it ascends. So the rotation at first is convex posteriorly and the hilum is anterior. So you can appreciate this, the hilum is facing anteriorly. Then the convex bit is posteriorly. That's the reason why now the convex bit will go to the lateral aspect and then the hilum will face medially. But now this is the accent that we see. Okay, so here we can appreciate the kidney systems. We have the pronephros, then we have mesonephros, and then we have the metanephros here. So we can appreciate that this mesonephric duct this is a mesonephric duct, is actually draining in the cloaca. That's another point that we need to appreciate. The mesonephric duct are draining in the cloaca because it has a very important function in terms of development of the reproductive system. Unless you can be able to see now, we have the vestigial pronephric duct that are developing in the neck region, the cervical region. Then the mesonephric ducts are actually in the thoracic and the abdominal region. Then the lumbosacral will have now the metanephros. Okay, so we need to discuss about the cloaca. So regarding the cloaca, is actually a connection between the allantois and the hindgut. So in this image, you can see the allantois is joined with the hindgut using the cloaca. So an important thing happens, which is development of the urorectal septum. So this is a urorectal septum. The urorectal septum divides now the genital system, the urogenital system, from the digestive system. And through that now we appreciate that the ureters, the bladders, and the urethra will be anterior, and then the rectum and the anal opening and the anus itself will be posterior. And that is what is being depicted here. So we have the urogenital sinus being the anterior aspect of the rectum of the cloaca. Then we'll have the anorectal sinus being the posterior part of the cloaca, and this is the urorectal septum. So our mesonephric ducts at this point will be opening now just below the developing bladder, and that is important. Then you can appreciate now the anterior aspect in males will be giving us the phallus, and this phallus is the one that is going to give us the penile urethra and the clitoris in females in the reproductive system. So let's talk about the bladder. So we needed to talk about the cloaca because in the cloaca, we talked about the urogenital sinus. So this is a urogenital sinus, as you can see here. This is a urogenital sinus. So presence of the septum, dividing it into two, urogenital sinus anteriorly, and then the anorectal sinus posteriorly. So ideally, the bladder comes from two parts. We'll have a vesical part of the urogenital sinus, that is the inferior aspect of the urogenital sinus, giving us the epithelium of the bladder. Then the caudal end of the mesonephric ducts. So we have, these are the mesonephric ducts. The caudal ends will give us a trigone of the bladder. Then we'll have the splanchnic mesoderm. The splanchnic mesoderm is the mesoderm that is surrounding now this urogenital sinus will give us the detractor muscle. So the smooth muscles of the bladder will come from the splanchnic mesoderm. Then within time now, the mesodermal epithelium is replaced by the endodermal epithelium. So appreciate that the initial epithelium of the bladder comes from mesodermal origin, but with time, it will become replaced by endodermal epithelium. That's the reason why now this vesical part of the urogenital sinus, the cells will migrate and form the epithelium of the bladder. And then the other thing is that now the urorectal septum divides the cloaca, as we mentioned earlier, into the dorsal anorectal canal and the ventral urogenital sinus. So the ventral urogenital sinus will divide into various parts. You'll have a cranial vesical part that forms the bladder. We talked about it. And then the middle pelvic part forms the urethra, as you can see here. So this is a cranial part of the urogenital sinus. It will form the most of the part of the bladder. Then the pelvic part or the middle part will form the urethra. Then the phallic part now, these ones will have information of now the penile part of the urethra and even in forming the primordium of the penis and the clitoris. So that one is important in that regard. So you can see this is a urogenital sinus. So the urogenital sinus will form, like most of it will help in terms of formation of the bladder, then the middle part will form the urethra, then the anterior or now the distal aspect will help in formation of the penis and even the clitoris. So you can appreciate here that we have the clitoris and the penis developing in males and females respectively. Okay, regarding the bladder now. So the bladder, before we go to that, the bladder, abdominally, ideally is located in the pelvic region after around the sixth year. So it's actually found abdominally, then it descends downwards. So it's abdominally located. Then as time goes by, it descends downwards. So in a child who is about like 3 years or 4 years, when you're having now the descent of the bladder, you'll appreciate that it's somehow above the pelvic region. But that's not, it's actually something that is normal. But now if it remains present in the abdomen, it may be something, maybe an anomaly. Some of the anomalies of the bladder that we have is that you can have urethral anomalies. You can have congenital bladder megacysts. These are now the diverticulum of the bladder. Then you'll have extrophy of the bladder, and then you'll have extrophy of the cloaca, also known as cloacal extrophy, also known as bladder extrophy. Those are two anomalies that we'll appreciate. So the first anomaly that we see here is actually bladder extrophy. So this one is failure of abdominal wall muscles. So failure of formation of the anterior abdominal wall muscles, making now the bladder to be exposed. Yeah, so actually you can be able to appreciate this is bladder extrophy. And then these are now the urethral anomalies. You can appreciate the allantois is connected. So the urethra is connected to the bladder. So remember, the upper part of the bladder embryologically is connected to the allantois. So that connection is supposed to degenerate. If it doesn't degenerate, it will give you a urethral fistula. So you have a patent lumen there. Then on this point, you can appreciate this is a sinus. So urethral sinus, then is a diverticulum. So the other is bladder diverticulum, the one that will now come and give us the megacyst. And then here we can appreciate we have a cyst. So this cyst sometimes you will collect, it contains some fluids in it. And then this is now the bladder diverticulum, so giving us the various megacysts. So you can appreciate the extensions of the bladder. So we talk about the urethra now. So the urethra, we talked about it coming from the phallic part, coming from the urogenital sinus. So let's talk about it. So you have a prostatic urethra. So remember the urethra has 4 parts. It has a preprostatic part, prostatic part, membranous part, and then a penile part. So the prostatic urethra, it develops from 2 locations. So the upper part or the upper half comes from the vesicle, urethral canal, and then the lower half comes from the urogenital sinus. So that's the prostatic part of the urethra in males. What about the membranous urethra? The membranous urethra comes from upper parts of the pelvic part of the urogenital sinus. So both some part of the prostatic urethra and the membranous urethra will come from the urogenital sinus. And now the proximal part of the prostatic urethra will come from the vesicle urethral canal. The penile urethra, as we talked about, this one it will come from endodermal in origin, so from the urethral plate, and then so from the urethral, this is a urethral plate here. So what happens is that the 2 urethral folds will unite, and that's the reason why now the penile urethra will be lined by the endoderm. So remember, this urethral plate is endodermal in origin, and that's the reason why now the penile urethra will have different types of epithelium. Yes, and now failure of formation of this urethra on its normal location or opening on On abnormal locations, you'll have epispadias and hypospadias. Yes, so those are now the exemptions of the various parts of the urethra. So an assignment to us, you can go and check the various types of epithelium that is lining the penile urethra. What about now the adrenal gland? So the adrenal gland is an important gland of the body, comes from the various places. So it has two sources majorly, a cortex which comes from the intermediate mesoderm, and then the medulla, which comes from the neurocrest. So this is a cortex, and then is a medulla, developing that medulla. So the fetal cortex and the adult cortex ideally comes from the intermediate mesoderm. Then the medulla comes from the neurocrest cells, which give rise to the sympathetic ganglia. So those are the chromaffin cells now. So it develops in the 6th week, site now between the root of the dorsal mesentery and the developing gonads. So that's it. And then it's ideally very large in intrauterine. It's very large intrauterine. Then as time goes by, it reduces in size. Some of the anomalies that you can have on the adrenal gland is that you can have congenital adrenal hyperplasia. So that means one part of the cortex of the medulla, cortex or the medulla maybe is larger than the rest. So that means you'll have overproduction of maybe a certain type of hormone in that regard. So that is congenital adrenal hyperplasia. Then you can have pheochromocytomas. So pheochromocytomas are actually tumors of the adrenal gland or the adrenal tissue that is occurring in a different location apart from the upper pole of the kidneys. So they just produce excess epinephrine and norepinephrine. So they're actually containing the medulla parts. Most of them contain the medulla parts of the adrenal gland. And now this the summary that we talked about. We can go through it at our own times, but you can appreciate the chromaffin cells. They will ideally migrate and come to form the medulla of the developing adrenal gland, and they'll come from the neurocrest cells. Okay, so let's talk about some anomalies. So the first anomaly is the renal agenesis, so complete absence of the kidney, renal hypoplasia, that is underdeveloped kidney, fetal kidney lobulations. Remember we talked about it embryologically, that it's the kidney is lobulated. Then with time, the changes that happen is that it smoothens. We'll have congenital polycystic kidney. So this is where now you have a failure of the collecting system. So the blastema and also the ureteric bud, they didn't merge well. So that's the reason why now you'll have an excretion of urine, and yet the urine collects in the blood in the kidneys to give you multiple cysts. That is congenital polycystic kidney. Then you have horseshoe kidney, that is now you'll have the fusion of the inferior poles of the kidney. Malrotated kidney, so it didn't rotate on its normal location or its normal point. Then we have renal tumors. So renal tumors, majorly the two most common ones, we have Wilms tumor and the renal cell carcinomas. Then the other one that we'll have pelvic kidney. So remember, the kidneys are supposed to ascend, but if they fail to ascend, they'll remain pelvic kidneys. Accessory renal arteries, that is how you have more than two or more than one artery supplying a kidney. So you'll have about now 1, 2 to 3 or to 4 renal arteries supplying the kidney. You'll have the thoracic kidney. We have cross renal ectopia. Now, one of the kidneys, we have two kidneys on the same side. Then you'll have duplex collecting system. So in duplex collecting system, you have two ureters, or 2 or 3 or 4 ureters. For the ureteropelvic junction obstruction, this one will lead to just the constriction of the ureteropelvic junction. The constriction becomes more constricted, and hence you can have hydronephrosis and the rest. Then you have retrocaval ureters, that means they are found behind the inferior vena cava. And now here we start with the anomalies. The first anomaly that you can be able to look here. So this is a kidney. On this other side, you don't have a kidney. So this one is renal agenesis. So because you're just seeing one kidney. For the other anomaly, we have renal hypoplasia. So here we can appreciate we have a kidney which is normal size, but now here we have a underdeveloped kidney. So renal hypoplasia or renal hypogenesis. Then you have this kidney, these two kidneys here. Yes, they are functional, but they are lobulated. So it's kind of fetal kidney lobulations. The image on our far right shows us these two kidneys being fused at the distal end. So these are horseshoe kidneys. So they resemble the shoes of a horse. Then you have now these ones. These one are congenital polycystic kidneys. So you can appreciate the multiple cysts. So remember, these cysts, they can be congenital, they can also be acquired. But most of the time, this polycystic kidney, they usually come across when you have mutations in the PKD, gene in chromosome 16 or in chromosome number 4. And most of they can also, those polycystic kidney disease, they can be autosomal recessive, they can be autosomal dominant, of which the autosomal dominant is the most predominant one. Then here we can appreciate, we have the liver, these are the ribs, these are the lungs here, and then we have this kidney. So this is thoracic kidney. So this thoracic kidney is actually found in the thorax. So it over ascended. Then we can appreciate now we have the kidneys here. So these kidneys, they're found on the same side. So this is crossed renal ectopy. Ideally, they're supposed to be on different sides. Then on this end, you can appreciate we have two different ureters. So this one is duplex collecting system. Then on this point, you can appreciate we have a ureteropelvic junction obstruction giving us collection of urine here. So this leads to hydronephrosis and hydroureters. That is even the mega ureters. So this hydronephrosis. So ureteropelvic junction obstruction giving us hydronephrosis. Then this is the horseshoe kidney. So remember, these are horseshoe kidney, so they are fused to the poles, so they can't ascend because of the various arteries. You'll have inferior mesenteric artery, you have the superior mesenteric artery, giving the obstruction. So they can't ascend into the abdomen as we talked about. Then here we have the horseshoe kidneys. They are fused at the inferior poles. And then the image here is that we have a pelvic kidney. So you can see this kidney on our right has ascended to its normal location, but now the other one hasn't ascended. So the congenital anomalies of the urinary system, you have others more. So you can appreciate here you have accessory renal arteries. So at this point, you have about 2 renal accessory arteries. So you have the main one being here, then these are other 2. Similar case on this image, we have 2 accessory arteries. Similar case now, we can also have ureter that is posterior to the inferior vena cava, and this gives us a retrocaval ureter. So this retrocaval ureters gives us the mega ureters that you can see here. Similar case, the retrocaval ureters in this image. Then at this point, we talked about the bladder, the verticulum. We talked about bladder extrophy. This is bladder extrophy. And now here, this is now cloacal extrophy. What's the difference between bladder and cloacal extrophy? So in the cloacal extrophy, you'll see both the bladder and some part of the urinary system and some other part now of the distal aspect of the hindgut in the cloacal extrophy. So, and then the cloacal extrophy is large than bladder extrophy, but the most common one in exams is the bladder extrophy. And then we talked about these anomalies. So we'll have the urethral fistulas, we'll have urethral sinus, bladder diverticulum, and the urethral cysts. Then this anomaly here is important. So you can see you have a urorectal fistula, so absence of the urorectal septum. And this urorectal fistula comes with anal atresia. So the anal pit is closed, as you can see here, but you have the urorectal fistula. So the hindguts is connected to the urinary system. So that is the urorectal fistula. And at this point now, this image is a very beautiful image trying to show us the accent of the kidney. So this one is not an anomaly ideally, but sometimes you can have an anomaly of it if they fail to ascend, so you'll have the pelvic kidney. But this is a very good image showing us the accent of the kidneys. Yes, so they're supposed to ascend. And then this tumor now is showing us the Wilms tumor. So this one is Wilms tumor. And then the Wilms tumor, the Wilms tumor will have three components. So we'll talk about it having epithelial parts, it containing a stromal part and the mesenchymal part. So it will contain a lot of structures in it. So we can go and check on the structure that are found on the Wilms tumor. But this Wilms tumor is found on pediatrics. And then, yes, so that's the end of it. I did just remind us that if you can't fly, then run. If you can't run, then walk. You can't walk, then crawl. The bottom line is that you keep moving. You're just moving forward. So every time, make sure you're moving forward. So at this point, I wish us all the best in our medical practice and also as medical students in our exams and as we interact with one another. So with that, see you in our next video. Thank you.